we're very excited to present data updates from the Javelin Bladder 100 trial. And to remind the audience here, the Javelin Bladder 100 trial was a practice-changing study that was published at the New England Journal of Medicine as of September 2020. The study asked the following question. What is the role of avelumab anti-PD-L1 plus best supportive care as switch maintenance therapy versus best supportive care alone in patients who have completed induction platinum-based chemotherapy and achieved response or stable disease? The trial showed a significant overall survival benefit with avelumab as switch maintenance therapy in those with response or stable disease, with a significant prolongation, statistical and clinically meaningful difference in overall survival, as well as progression-free survival in all comers, regardless of PD-L1 expression in the tumor, as well as the subset of patients with PD-L1 high tumors. At ASCO 2021 virtual meeting, we want to update the data and look at particular subsets of patients just to inform discussions and answer questions regarding particular clinical scenarios. The first question was, is there any particular difference in the benefit with avelumab in particular subset of patients based on clinical features, for example, locally advanced unresectable disease versus metastatic distal metastatic disease, or based on the origin of the primary tumor, upper or lower tract, as well as patients who had lymph node only disease, or also the question about patients who had PD-L1 high tumors and they were not fit for cisplatin, then they got carboplatin gemcitabine followed by avelumab. Overall, we saw that the benefit with avelumab as switch maintenance therapy plus best supportive care was consistent across the board in different subsets of patients. Obviously, there are different degrees and magnitudes of benefit. Some people benefit more than others, but overall, I would say that the significant overall survival and progression survival benefit is important, and it seems consistent across the board in different subsets of patients. So in clinical practice, my take home is I do not use any particular clinical subcategory or any molecular biomarker. I offer avelumab as switch maintenance therapy in every patient who has no contraindication to immunotherapy and has achieved response or stable disease to platinum-based chemotherapy. We also look at another clinical question, which was, does the treatment-free interval between the end of chemotherapy and initiation of avelumab matter in terms of the benefit achieved with avelumab maintenance therapy? And the treatment-free interval in the Javelin Bladder 100 trial was between 4 and 10 weeks, again, between the end of chemotherapy and the initiation of avelumab maintenance therapy, or best supportive care alone. And we broke down the subsets of patients into different treatment-free intervals, 4 to 6 weeks, 6 to 8 weeks, 8 to 10 weeks, and we saw that the benefit with avelumab maintenance was consistent across the board in the different subgroups of patients, regardless of the treatment-free interval. However, if you ask me in my clinical practice, what do I prefer? I discuss with the patient, of course, the patients want a break after chemotherapy, but my worry is potential progression if I wait too long. The progression-free survival, the median progression-free survival is short, maybe about 2 months after the end of chemotherapy. So I tend to offer avelumab maintenance earlier than later, sooner than later. If the patient agrees, of course, we tend to start it earlier and not wait for the entire 10 weeks, just to avoid any interim progression. The third abstract was the one I presented. The previews were presented by Professor Pauls and Dr. Sridhar. The third one was presented by myself, and we looked particularly at the time interval between randomization in the Javelin Bladder 100 trial and the completion of the next line therapy. And the impetus to do this analysis was to see whether avelumab versus best supportive care alone has any impact on how long people stay on the maintenance component and the second line therapy in this particular setting. Obviously, we would love and prefer to have granularly the data of the second line therapy and to look at the PFS2. However, we did not have that granularity. So we tried to approach this question by measuring the time between randomization on the trial and completion and of the next line therapy, the second line therapy. And we saw that avelumab plus best supportive care significantly prolonged the time between randomization of the Javelin trial and the completion of next line therapy, corroborating overall the benefit with this agent in the maintenance setting, the first line setting of advanced urothelial cancer. Overall, we're continuing the program and we are planning further manuscripts. We have a manuscript looking at biomarkers and translational correlative studies. We look at patient-reported outcomes, quality of life, and different subsets of patients in order to inform the literature and answer practical questions. But overall, I would say that in the clinical practice, the new standard of care, as I mentioned earlier, is for patients who have no contraindication to immunotherapy and they achieve response or stable disease to platinum-based chemotherapy as induction. Then you can continue with switch maintenance therapy with avelumab based on this level 1 evidence. I would like to thank, of course, all the patients and families participating in this very important trial that was open at Seattle Cancer Care Alliance, our center, and of course, all the co-investigators and staff from multiple cancer centers around the world. This was a large trial of 700 patients and lots of people, hundreds of people worked very hard to get this study done. And of course, I want to thank the audience for the attention. Hopefully we can see each other when it's safe in person, probably next year. And in the meantime, stay safe and well. Thank you.